Okay, so welcome everyone for today's MES-CoBraD project webinar. I'd like to thank you all for joining us. I'm Oliver Blake and I work for LIBA Europe, which is one of the 14 partners that make up the MES-CoBraD consortium. And today I'll be your host for this webinar. I'll be here introducing you to my colleagues from the project who will talk you through the MES-CoBraD platform, highlighting its features and benefits, and how it can advance medical research and patient care for complex brain disorders. So before we do that, I'd like to remind everyone that this will be a recorded session. So if you have any questions, you can just put them in the chat while the speakers are doing their presentation. And we have someone monitoring the chat, so they'll be relayed to the speaker at the end. Just please highlight who you would like to answer the question if it's for someone in particular. Also, as it's recorded, I already mentioned if you could keep your cameras off if you prefer not to appear on the recording. And at the end, if you do want to appear on camera and speak, you can open that and then participate in the discussion section at the end. So that's the house rules, and now a brief overview of what to expect from the webinar. So next, we'll hear from our project coordinator, Christos Tanos, who will provide a brief background on the project and introduce you to its overall aims. And then we'll dive into the main section of today, which is the stakeholder perspectives on the MES-CoBraD platform. First, it will be that of the researcher, then the clinician, then the patient. All in all, this should take around 45 minutes with 15 minutes for each, which will save 30 minutes for a discussion and Q&A at the end. So any questions which come on the chat will be relayed to the speakers, and we'll also invite Christos back to moderate this discussion. So at that, I will hand over to Christos to introduce you to the MES-CoBraD project.
All right. Hello, everyone. My name is Christos Danos. I'm a research director at the Decision Support Systems Laboratory of the National Technical University of Athens. And I am the coordinator of the MES-CoBraD project. In this brief presentation, I'll provide a high-level overview of the MES-CoBraD project and platform, laying the groundwork for you to understand the subsequent presentations. The brain's intricacy presents numerous challenges, particularly when it comes to complex brain disorders, or CoBraDs, as we call them here. These conditions, which include epilepsy, dementia, and sleep disorders, present a range of clinical, research, and technological hurdles. From a clinical perspective, issues include frequent underdiagnosis and misdiagnosis, and ineffective treatments. On a research front, we grapple with gaps in our understanding of CoBraD pathophysiology and numerous trial failures. Technological challenges include the lack of integrated data platforms and advanced analytics tools. Traditional healthcare systems often struggle to meet these challenges. They tend to rely on intermittent clinical visits and a limited range of data types. This often results in incomplete diagnosis and less effective treatment plans. The scarcity of real-world continuous data makes these worse, often leading to a fragmented and incomplete understanding of the patient's condition. Addressing these multidimensional challenges in CoBraDs requires a concerted boundary-crossing effort. The EU-funded MES-CoBraD project is strategically designed to tackle these challenges head-on, enhancing diagnostic accuracy and optimizing therapeutic interventions. A key aspect of this is the platform's capacity to leverage real-world data, gathering from diverse populations and geographies. This not only enriches the data sets, but also adds a layer of complexity and authenticity to the research. The MES-CoBraD platform is more than just a data repository. It's designed as an advanced analytical tool for research, equipped with the capacity for complex hypothesis testing. Moreover, it holds the potential to contribute to clinical practice, offering personalized and targeted diagnostic and treatment plans. By doing so, MES-CoBraD aims to enhance patient outcomes and contribute to the sustainability of healthcare systems, positively impacting patients, caregivers, and society at large. Navigating the complexities of brain disorders necessitates an advanced integrated approach, which is precisely what the MES-CoBraD platform aims to offer. Functioning as a cloud-based applied research ecosystem, the platform represents the entire process from the collection and anonymization of real-world data to the application of artificial intelligence algorithms, data analytics and visualizations, up to the execution of hypothesis testing and other scientific tools. The data are securely stored anonymously and accessed through the platform, offering researchers and clinicians a shared repository for the research. However, the platform's capabilities extend beyond data collection and analytics. It serves as an essential tool for clinicians, offering critical guidance on possible differential diagnosis and treatment options as an expert system for clinical guidance and support, thereby elevating the standard of patient care. Furthermore, its open science-focused architecture facilitates cutting-edge research by providing researchers access to multiple data sources in a highly collaborative interdisciplinary environment. With impressive metrics, over 600 participants and more than 5,500 real-world datasets, among others, the MES-CoBraD platform is a testament to what can be achieved when a technology, science, and medicine converge in a coordinated effort to combat complex brain disorders. The MES-CoBraD platform, as we've seen, is more than an assembly of technologies or a static database. Instead, it's a dynamic, evolving ecosystem that adapts to the fluid landscapes of medical research and healthcare practice. By leveraging real-world data from diverse socio-demographic landscapes, it transcends traditional data limitations and embodies a comprehensive approach. These data form the basis of our highly secure, scalable platform, enabling not only cutting-edge research, but also the potential to transform clinical practice. In essence, the MES-CoBraD project symbolizes a paradigm shift in tackling complex brain disorders. It serves as a hub for interdisciplinary research and aspires to be an integral component of new healthcare model, one that prioritizes precision, evidence-based approaches, and patient centricity. As we delve deeper into the perspectives of researchers, clinicians, and patients in the subsequent presentations, we will explore how MES-CoBraD embodies a feedback loop. Data from clinical applications and patient contributions are anonymized and fed back into the system, propelling both medical and IT research. This cyclical process, in turn, drives innovations in diagnosis and treatment, fostering a sustainable and continuously improving scientific ecosystem. Thank you very much for your attention. As we delve further into the webinar, we will have the opportunity to explore the various facets of this project in greater depth from the perspectives of researchers, clinicians, and patients.
Okay, thanks for the introduction there, Christos. You'll be invited back later to ask some of the speakers' questions. So I would hand over to Javi and Louise, and they'll begin going from the stakeholder perspectives, talking about the perspective of the researcher, which will start to shed some more light on that high-level introduction Christos just spoke us through. So over to you. Thanks.
Thank you, Oliver. Well, hello everyone, and thanks for attending this webinar. I am Javier Arran from Sant Pau Hospital, and my colleague is Luis Eduardo Rendao from Uppsala University. And we will talk to you today about MES-CoBraD project from a researcher perspective. As it has been previously explained, MES-CoBraD is an interdisciplinary project combining real-world data from multiple clinical and consumer sources through comprehensive, cost-efficient, and fast protocols towards improving diagnostic accuracy and therapeutic outcomes in people with complex brain disorders, CoBraD, as reflected in neurocognitive, dementia, sleep, and seizure, epilepsy disorders, and their interdependence. So the main question here would be, why should a researcher or clinician be interested in this project? One of the main reasons is because MES-CoBraD is creating a dataset with reliable source of data for complex brain disorders research and a source of multiple tools to evaluate different data types. Of all groups forming the consortium, 4 clinical sites across Europe are responsible of incorporating participant data. Those sites are Rabi Medical Center, King's College of London, Neurological Institute of Athens, and Instituto de Recerca Hospital Sant Pau. This feature allows us to capture a broader spectrum of genetic, environmental, and cultural factors and to detect subtle associations or rare phenotypes. So which kind of data and how we collect it? Next slide. The MES-CoBraD project identifies 7 categories of real-world data, allowing for deep phenotyping of people with neurocognitive disease, epilepsy, and sleep disorders, and assessment of their comorbidities towards achieving precision and personalized medicine goals. Core pilot data have been acquired in an harmonized manner across sites with additional types of real-world data differing according to partner site specialization. The categories of real-world data would be the first one, current clinical symptoms and medical and social history derived from information given by patients and their caregivers, directly or indirectly, collected by expert evidence-based questionnaires and structured interview question trees. Second one would be neurological examination and neuropsychological testing. The third one would be neuroimaging with a special focus on brain magnetic resonance imaging, MRI. The fourth would be biological samples as blood biomarkers and cerebrospinal fluid that are stored and processed for several neurodegenerative disease biomarkers, including but not limited to beta-42, beta-40, p-tau181, neurofilaments, and several proteomic variables measured with Olink. The fifth one would be neurophysiological data, especially non-invasive techniques as polysomnography and electroencephalography. The sixth one would be medical device, for example, CPAP, and the seventh would be consumer technology as actigraphy. The categories collected at baseline would be clinical and social history, including structured questionnaires. The baseline assessment is followed by 1-week multimodal assessment comprising brain rhythm physiology, cognitive, and biosample assessments. Actigraphy and sleep diary are administered on day 1 and are assessed continuously throughout the week. And if a person is using a medical device, a CPAP or vagal nerve stimulator, their information will be captured as well. Between 5 and 9 days of actigraphy testing, participants undergo an overnight nested protocol that would consist in pre-sleep and post-sleep cognitive assessment and blood extraction, and then overnight neurophysiological testing comprising electroencephalography and polysomnography. In addition to the both baseline and 1-week multimodal assessment, additional real-world data are acquired in an independent time frame, ideally 2-3 months of the protocol, and include neuroimaging and other remaining data. In addition to prospective data collection, we are also collecting data retrospectively with the above mentioned real-world data specifications. Go to the next slide. So the harmonization across sites of the acquisition instruments for collecting clinical symptoms, history, physical exam, and neurophysiological tests allows us to standardize data collection and increase the reliability of the results provided by the platform tools. The instruments would depend on subcategories assessed, ranging from Pittsburgh Sleep Quality Questionnaire or Stop Bank for sleep complaints. The next slide. To GDS for mood or PCRST, free and acute selective reminding test for memory. We also include digital tests as TAPCAT for memory, executive and visuospatial assessments, and many other tests. So, in the next slide. Now I'm going to talk briefly about the consideration about secure data upload to the platform and secure data sharing, which will be further also developed. And well, retro and prospective data continue to be collected and stored locally by each partner involved in the project. This approach ensures that data remains secure and controlled by the respective clinical sites. To maintain the privacy and security of personal data, technical consortium partners have made significant advancements in anonymization process. To ensure that data upload to the platform and data sharing between groups is secure, an updated edge model has been developed and implemented to cover all supported real-world data types, including questionnaires, magnetic resonance imaging, and actigraphy. This enhancement ensures that personal data is removed before ingestion into the cloud counterpart of the MES-CoBraD platform. Following anonymization, the data is ingested into the data lake built and maintained by the technical consortium partners. So, to conclude, the first part of this presentation, one of the main and most important objectives of the project is the creation of a reliable source of data for complex brain disease research and the development of a source of multiple tools to evaluate distinct data types as EEG, MRI, actigraphy, statistics, which outcomes will support the clinicians in their diagnostic or decision process. For us, it is important to generate a reliable data source to answer different scientific questions. Our protocol covers many relevant aspects of complex brain diseases and is being applied across Europe, building an ideal dataset with a standardized evaluation process to answer many scientific hypotheses. Now I give way to my colleague, Luis Eduardo.
Hello, everyone. Thank you, Javi, for your introduction. So, as Javi has introduced it, we'll discuss about the benefits of having MES-CoBraD platform as a reliable tool for research. MES-CoBraD, first of all, MES-CoBraD platform is a resource platform designed to empower scientific research by ensuring those three main aspects: data security, data integration, and advanced analytics. So data security was and still being a big priority to our project and to this platform. So ensuring that researchers can confidentially upload and manage patient data, knowing that security measures are in place to protect confidentiality and compliance with data protection regulations. Researchers will be supported by data anonymization tools that are able to identify and remove personal data from different file formats. Initially, file formats related to the standardized protocol that Javi introduced to you. So EDF, CSV, TXT, and including as well removing facial traits for MRI images, so-called MRI defacing. And users can also protect your data access by creating workspace for specific projects. So those workspace can be set to have specific data sets and users in a way that the researcher can be sure with whom he's sharing data in a specific project. So that integration was a big challenge since our main protocol, explained by Javi, involves different real-world data with distinct aspects and formats. So we have here, we collected questionnaires, sleep diaries, actigraphy, EEG. Actigraphy and EEG, for example, will be collected as a time series, so they have a completely different representation. So our platform ensure that all those different sort of data will be integrated in a proper way. So the platform allows researchers to integrate data from different sources, as I said before. This integration provides a comprehensive view of complex brain disorders, enabling us to explore connections and correlations that are not apparent when we, for example, analyze individual data sets in isolation. So here we can see we have a broader perspective of those diseases. The metadata manager, for example, is a module or two that researchers can use to organize variables and create a variable dictionary and register and also register a question to build a survey or a whole questionnaire, for example. I'm going to show you some pictures of those features. So the metadata manager, for example, we can create, delete, and edit abstract categories to tag variables, for example, with distinct components or meanings or facets, as you wish to call them, and then group them by similarities. So this can be a good solution for a researcher who is dealing with a data set that has one specific variable missing. Let's say that you're missing the sleep duration of a participant from from a specific questionnaire, and then you can check via those abstract categories what kind of variable can also say the same aspect. So variables can be registered and saved in a better way as well. Questions in your main properties can also be saved and registered, and then questionnaires that will be then associated to specific questions. So we have, via the metadata manager, we can create and edit all those variables classes And then we can associate them. So we can associate questionnaire to specific questions, question to specific variables, and variable to specific abstract categories. So those questionnaires can be later exported in AU survey. We have a specific feature for that, and then they can be edited, translated, and published. So the results will be automatically uploaded in the data lake. Make our life way easier. So regarding advanced analytics, to ensure advanced analytics, 3 different models were developed. So the CoBraD Builder, the Visual Analytics, and the Workflow Manager. By using them, researchers can generate customized reports and visualizations to answer specific research questions. The Workflow Manager will act as a final controller to register and perform your analytic flow. So the platform was designed to work like this, to be able to integrate artificial intelligence and expert decision. So this workflow will track all your analytic flow and keep track of it. I will speak more further about this feature. So the CoBraD Builder, for example, will help us to select data from this big data lake, filtering by a specific condition that fit each hypothesis that researchers are looking for. And then we will export this data as tables. So those tables will be used by visual analytics functions to perform a plethora of techniques that were selected by us according to variables from our standardized protocol. As a sleep researcher, for example, I like to emphasize the tools for PSG and AG analysis. We can, for example, easily summarize hypnogram results, calculate spectral components, and search for spindle and soul waves from EEG or PSG data. Here, for example, you can see how a EEG file can be shown in your platform, can be viewed in your platform, as long with its annotations and other aspects. Here is a simple outcome representing a Spearman correlation. This outcome can be later exported as CSV table. And for last, the workflow manager. So as I have mentioned before, the platform was built around this feature. This tool will control all the user actions regarding analysis, keep track of each step that was implemented, that it's a good solution to ensure reproducibility, because you're going to have the same workflows for your next data sets. So these workflows can be then concatenate to provide a more complex analysis, and will be read by or used by artificial intelligence to provide feedback and support to diagnosis and therapeutic process applied by clinicians. And that's all for my part.
Okay, thanks to Javier and Luis for introducing the researcher perspective on MES-CoBraD. For those participants who've joined in the last 15 minutes, thanks for being with us here today. We're about to move into our second stakeholder perspective on the MES-CoBraD platform. So I'll hand over to my colleagues, Ophir and Eliseos, to talk us through this.
Great. Well, wonderful to be here today, and thank you everyone that can join. So that was a good setup, listening to you, Luis and Javier, about research perspective using the platform. But naturally, I think a lot of clinicians would be interested in seeing or understanding how this project and how the specific platform relates to day-to-day clinical work. So we'll try to tackle and understand that a bit. These would be the major questions. Okay. So what does it mean, a platform, maybe for an explanation for clinicians? So we all work in electronic medical systems, and we input patient data. We use them mostly to register, write notes, but the question is if we have a similar system or a device that is also an electronic, but also feeds back with kind of decision support, and what Krista said initially. And I think it's an excellent question first to understand what's the challenges that we're faced day-to-day as clinicians that work in the field of complex brain disorders, neurologists, sleep medicine, epileptologists, and exactly how does the platform operate to give us or to answer those challenges. So first, I'd just like to touch a little bit about complex brain disorders and how they have a shared prevalence or secondary prevalence. It's worth to note that they're quite frequent in the populations. Just if you look at the sleep and circadian rhythm disorder, the general prevalence of the population, of course, is age dependent, is roughly up to a quarter of the individual. So that's quite a lot. Neurocognitive disorders range, of course, also an age group that can reach as high as 7% of the population, and in old, and of course, epilepsy and seizures with a prevalence stayed across a lifetime. But what you can also see in this graph is what would be the chances or the prevalence that someone has one of these disorders and he has a secondary. So for instance, as someone who deals mostly with dementia and Alzheimer's disease, I can tell you that sleep and circadian rhythm disorders are quite frequent. I would say these numbers are accurate. About 70 to 80% of the people who have a major neurocognitive disorders represented by Alzheimer's or other diseases have sleep disorders quite frequent. And this comorbid complication and prevalence makes it challenging to give good clinical care to patients without involving additional experts. And that's where things get more complicated. And this, of course, brings us to the next challenge: is underdiagnosis, misdiagnosis, and untimely diagnosis, which means diagnosis at a very late stage. And we know that at least all these three conditions are severely underdiagnosed. You can say that the rates of underdiagnosis of dementia, so neurocognitive, are very high, be as high as 60% in high-income countries, not even in developing world regions. So we all know that's a very significant barrier to good clinical care. And then, of course, there's limited access to specialty care, as I recently mentioned. And we all know that there's a benefit for early stage diagnosis across all these complex brain disorders. And lastly, it's worth to mention that they're quite frequently misdiagnosed as psychiatric disorders. People who have sleep disorders might think it's pain or sometimes different changes in life that are not specifically related to sleep. So all of these, of course, limit diagnosis and limit our ability to manage these in due time. And then thirdly, there's, of course, the therapeutic challenge, that if there are therapies, sometimes they're not very optimal. They don't deliver a good required outcome, especially if they are given to people who have comorbid or not a very specific set of complex brain disorders. And in some cases, therapies are even contraindicated. They might worsen the condition. And of course, there's lack of therapy or lack of effective therapy. We know that from a pharmaceutical drug perspective, drug design is sometimes developed through a hypothesis-driven method. That, of course, takes time. Clinical trials require quite a while maybe to show a benefit. It's just an example. You can look here on the curve on your right and see the amount of drugs that were suggested for Alzheimer's disease from 1998 to 2017, and how many approvals there were. And lastly, of course, the limited amount of expertise prevents the appropriate administration of therapies or their appropriate selection, at least. So that's, of course, a challenge. And lastly, there's a social impact to be discussed in these conditions, that we know that various elements of an individual's social perspective, sometimes it is referred to academically as social determinants of health, can actually increase the risk for developing brain disorders, and can also alter the phenotypes. That means that a presentation doesn't look like the presentation that you would expect it to. Naturally, people of adverse social health determinants are more limited in healthcare. That, of course, precipitates the miss and underdiagnosis, and leads to even a more dismal life quality and morbidity and mortality. And of course, if this occurs in the setting of a population which is stereotyped, this can actually ingrain a brain or phenotype stereotypies into specific populations. So it has a wide social impact. Eliseus, would you like to maybe take a leap here and describe what you see as the value and thought of the
Let me see
the
if I
expert
can
system.
get
Yeah.
control. So, hi, I'm Melissa Scaraggiorgio from the Neurological Institute of Athens. I'm a behavioral and sleep neurologist. So, the idea here is that in having and using an expert system in a clinical setting, you satisfy diagnostic purposes. You can achieve deep phenotyping of participant or people that you see in clinic. You can instruct them as far as their prognosis and also some predictive treatment response. So whether somebody would respond to a certain condition, and also you can get feedback on what's the recommended next step as far as diagnosis or and pursuing certain therapies. In that setting, we use the different elements that were described before by Luis and Javi of the platform. So you need a metadata manager, you need the representation of the data in an abstract setting as well. You need a knowledge base, meaning that the results of all the data that you have, in addition to professional guidelines from associations, so the American Academy of Neurology, for example, for us, or the European Academy of Neurology, or the data-driven results from an analysis, or your own, as a clinician, your own preferences in settings where there is no specific guideline, where you have a preference or given situations of one medication versus another, or one diagnostic test versus another. And then this knowledge feeds into the workflows that were described, into what's the information now, how do I process it, and then after getting the first results using the data analytics that were discussed, get the first recommendation that you can then use to follow up. All this now you place in an ethical and legal framework. That means that the data remains in your institution. It's not something that the personal, I should say, healthcare data that are identifiable. You heard before about data that go into the cloud are actually post-anonymization, but also post-depersonalization. We have defacing of MRIs. So these are key features as far as analytics that need to be done on a cloud level and get feedback from there. Otherwise, on a very simple level, you can do a lot of this stuff within your institutional server on an edge module. And then we have our protocol, as you heard, we have prospective data, we have retrospective data that we pursue. And the outcomes that we follow are not just clinical in the sense of biological outcomes of a biomarker or a phenotype of a clinical outcome assessment, as we say, as far as patient perception, but also social outcomes that also apply to the day-to-day life of a person. Can I, next slide. There we go. So you heard about the protocol. I don't need to say it again. The point is, though, that within this framework of the MES-CoBraD platform, you can choose your flows of clinical protocols. Let's say, for example, you're a purely sleep clinic. You can have something where you have your clinical examination followed by actigraphy or not, depending on the information you get from a patient. And then you can decide if somebody also reports things like snoring, where you're concerned for sleep apnea, you can refer them for, or the algorithm can refer them for a sleep study. The point of this image is that we're talking here of a precision medicine approach where you get as much information as possible towards developing the personalized tools and flows that apply to a patient or a group of patients that have common characteristics. So the more information you have, you can get these algorithms and more data, of course, to be better trained, and then you can develop or select the personalized tools for each person in a real-world setting. As an experience, what does that mean? It means that the patient and the caregiver, they can enter their information from home. So they enter a portal. You saw before some questionnaires that we have. There's also, depending on the setting, options for uploading other types of data like imaging or EDF in certain settings. But clearly the questionnaire data is something that's straightforward in getting the first information in. And then the system itself doesn't wait for the clinician to see them. They can actually do in a dynamic setting a first analysis. Let's say you mentioned that in a questionnaire you have features that are concerning for snoring. Then the follow-up could be, do you also have, let's say, daytime sleepiness? Or do you have, or have you ever had a sleep study before? So all these questions that you would otherwise get from, have the clinician spend time on, you can get that information early on through these dynamic questionnaires. And then you see, of course, the clinician, but by the time you see the clinician, there is a first guided recommendation to the clinician. So the information, the feedback doesn't go to the patient. The feedback goes to the clinician. It's still a fully supervised process. And I think this is something for the years at least to come. We have to retain it within the supervision of an expert clinician because Dr. Google always can lead to mistakes for patient decisions if it's used by non-experts. So at least until these tools are fully validated, an expert gold standard by a clinician is required. And then the clinician can decide, is this something that is recommended? So let's say the AI system, the expert system, recommends that you have a sleep study. Is it something that the clinician agrees based on the data, or is it something that's not valid? And that's where the purpose of the research that we do within this setting is to validate these flows. And if you think of it, these expert system flows follow the general principles of what we do in clinic. What do? You come in, you have a chief complaint. You may be already on an electronic healthcare record, so that means that you have data in there. So what medications have been prescribed, or whether you have a previous MRI or a neuropsychological test, and so forth. So if you say, I'm forgetful, then this information is accessed and processed in the background and fed into the knowledge base and the different flows of the knowledge base. Which means that if you already have, let's say, atrophy in your MRI that's analyzed through automatic tools, or somebody has already scored it, and then you also have a low neuropsychological test, then that is fed into the primary flows, as we say, of your main complaint. So memory would be associated with certain flows, and these flows would indicate to the clinician as a main outcome that, you know what, I'm concerned that this person has dementia or mild cognitive impairment, possibly of this type. Why? Because, and that's where explainable AI comes in, because they satisfy this and this and this criterion. And then if there's information that's missing, let's say this person comes in with memory complaints and they have a neuropsych testing, but they're missing an MRI. The recommendation may be to, first of all, to the clinician, you know what, this seems to be something that goes within this category of disorders. So you're given a differential or possible differential, but I'm missing that critical information to give a definitive answer based on what you have populated in my knowledge base, the guidelines and data-driven knowledge. So you get that missing information requested by the system to prescribe, let's say, an MRI. And then you enrich the data, and this goes in a circular form. Sometimes also you may have a person coming in with one complaint in the screening. So we always, when you see a physician, they're supposed to do a review of systems. So critical systems that relate to your primary complaint. And then you may also mention snoring. This way you have both a main neurocognitive disorder complaint, but also a sleep complaint. And as you saw at the beginning, these conditions are highly comorbid. So it's very critical also to assess them in parallel effectively, because we know when we treat one, it's actually better for the other as well. And that's the big picture as far as a clinician's experience in it and how they can help patients in the process.
Okay, thanks, Elsa Sofia. Now we'll move on to our final presentation of the webinar before we get into the discussion, where we'll invite all speakers back. So I would ask Antonio and Francesca if you could, one of you could share your screen, or maybe Ophir, if you stop sharing your screen as well, then we'll move into the final section of today. If anyone has any questions, I'd remind you to put them in the chat, but you're also welcome to raise your hand and join the discussion at the end as well. So yeah, over to Antonio and Francesca.
Thank you very much. Let me share the screen. Is it working?
Yeah, that's good. We can see the screen. So thank you.
This part of the presentation is about the importance of patient and public involvement, the relevance, how this public involvement is important for this grant, and in general for all the conditions that we are discussing today. And Francesca is from the Cyber Ethics Lab in Italy. She's going to give us an advice as well about the ethics of this project. Hopefully it will work. What is the relevance? There has been a lot of papers recently regarding how patient and public involvement is important for our research project. First, we need to align the questions to meet the needs of patients, not for the research only, but what is important for patients. And we need to improve the quality for the participation in these studies. Basically, we need a lot of diverse perspectives, not only our clinical of our research aspects, but actually the patient's perspective into why is this important for a process, what is important for decision making. And we need to improve communication. This is one of the problems that we are having with many projects. The patients are not involved, they don't have enough communication. And that's the main aim of this particular subject. There are many fundings, agencies, and that are already working about PPI, but still it's a process that we have to work individually in all our research projects. What are the aims? Well, the main aim is to integrate patient and public involvement seamlessly at the planning and continuous phases of our project. This is the main aim. The PPI has to involve in all the different plannings. And how can we do it? Well, we need the output from patients. And these outputs is instrumental. We can shape the study, we can shape the research, we can give exactly what we need for these people and for the patients. The way to do it, discussing our project and our system with patients and public, and just to listen to them, just to listen what they are saying, listen to what are their opinions, and then try to have the perfect final approach for the MES-CoBraD, looking at what is needed in the public. There are many possible stakeholders group, including patients, family members, and clinical staff, and they already been consulted in this study. But this process has to be continued doing it in the next months. But basically, our strategy in this project is to ensure that the patients and the public can shape the study and the software design from the outset and throughout the project. We have a patient advisory group consisting of patient and family, in this case with epilepsy experience, with other conditions as well, and with diverse backgrounds, and they are going to be involved in the final software tool. And finally, we'll try an end of trial forum just to be prepared to learn from the projects. But what is the advice that we are getting from the patients? Well, that we need an earlier and more accurate diagnosis with the aim to have a better health and social outcomes. We need to improve the therapies, so to identify or not harmful interventions, just to decide what is the best intervention in any particular condition. We can try to find the best way to optimize the clinical evaluation time and just maybe to save the cost of care. For instance, sometimes online questionnaires or self-administered tablet-based cognitive tests, the combined PSG and EEG that we are discussing in this project, can be done by the patient. We don't need to bring the patients to the ward, to the hospital. Maybe we can find a way to do it independently. We have to identify the social determinants of health outcomes, and we need to find the policy recommendations for this. And finally, we have to disseminate our results. We have to find what is the best dissemination activities for this project. We need to access to metrics for informing public and policymakers, and we can have the data for use in material. And this is the way that we need to learn how to present this data. And that's the reason we need the patients as well. Because maybe sometimes we can present it in a scientific way, but we don't know how the patients will accept these presentations. And these are the purpose of the PPA engagement today. These are the initial questions that we have, and what is the perspective from the patients? How does the platform works? How do they know that this tool is safe? Why it's beneficial? How does the platform can help the condition of patients? Or is going to reduce the time of inactive doctors? These are the typical questions that we have been having from patients before. And this is what we are going to try to discuss today with our patients. Today we are going to have two patients, but let me just go first for the second stage. And I will leave it with you, Francesca.
Thank you, Antonio. And so, of course, till now we saw that using the platform can have many advantages for researchers, for clinicians. But what about the patients? Antonio already partially returned to their point of view, and of course, the awareness that they are being cared for with the help of a platform that uses also artificial intelligence, an expert system, can raise many questions, doubts, and even fears. Some of them you can see here represented. And if you can go to the next slide. So the first thing we can say to dispel these legitimate doubts is that the system has been designed and developed specifically to have the patient's rights at its very center, an ethical framework and a set of ethical requirements based on the principle of bioethics that you can see represented here have been outlined and then used to both design and assess the development of the platform through the entire life of the project. And also, of course, after the project ends and the platform will be released on the market, the assessment and the monitoring will continue. So we'll also gather the patient's feedback, of course, as Antonio said, because that is a very crucial aspect of the system working. Move to the next slide, please. It must be said that particular attention has been paid also to the quality of and the representativeness of data sets gathered. And this, together with the fact that the knowledge base that the system uses is extracted from human experts, and so it's not generated autonomously by the system, brings to a minimization of the possibility of biases, systematic biases introduced into the system. Of course, as we saw, data after being gathered is anonymized, so personal data are completely safe. And following an explainable AI approach, the doctors, the clinicians can access at any moment the variables, the data, the workflows that the system used to deliver a certain output. So we can say that the system, to the next slide, please. The system will never take autonomous decisions. And the human clinician remains always at the center of the therapeutic relationship. And we can say that he uses the MES-CoBraD platform as some sort of a tool to support him in the diagnostic process. So this is extremely important from the patient side. the clinician remains always accountable for his decisions. If you can move to the next slide. Thank you. So to sum up, what are the advantages from the patient side of using being cared for using the MES-CoBraD platform? Well, first of all, the fact that the doctor can spend less time using the platform on routinary tasks brings to the fact that he has more time for the patient, and so can spend more time building a positive and fruitful therapeutic relationship. And then the fact that the doctor has immediate access to a huge knowledge base, always growing, and to a shared protocol, state-of-the-art protocol developed by, some of the brightest research in the field, hopefully can result in amelioration of the diagnostic process, and to also an early diagnosis, which is very important for the therapeutic outcomes. Last but not least, also the patient can spare his time, because he can perform some tasks, some say tests or other things at home, saving the time and also the discomfort generated by having to go in person to the hospital or to the clinical center. And last but not least, he has the pride of contributing to the progress of knowledge and medicine. Thank you. That's all on my part.
Sorry, just to say that we have today two patients, families from patients that are very important, that has helped us in many research runs in the last months. And they are very happy to help us with all the questions that we can have. Heather Clare is the wife of a patient with epilepsy and learning difficulties. And she has huge experience in helping with research in different subjects and different projects. And Anne Lennox is the mother of a girl with very severe epilepsy, and she was treated with a new neuromodulation and surgical techniques in the past, and she has been seizure-free for several years. They have experience in newspapers, web pages, patient meetings, and other research panels. And they are very happy to answer all the questions that we can have, and from the patient and public perspective. And just for them, yes, I would like to say thank you very much for all the time and contributions to this project.
Okay, great. So that was all our presentations today. Thanks for all our speakers. Also, thanks for the impeccable timekeeping skills, because we're exactly on time. We have 30 minutes for the discussion section. So if you could stop sharing your screen, Antonio, and then I will ask Christos to come back and we can get into the discussion section. Also, thanks for Anne and Heather for being here today, and we'll make sure that we hear from you in this section as well. But I'll hand over to Christos, who's been listening along and has some questions for the speakers today.
All right. Hi all again. Mostly trying to contribute to the discussion and the understanding of what MES-CoBraD aims to achieve. I have some questions that will address to our colleagues based on the perspectives that they have presented. So, as a recap of the discussion this far, we are talking about a feedback loop between a system which is used for performing research, so one where data is anonymized and uploaded, and on which data analytics and hypotheses and scientific hypotheses and artificial intelligence algorithms are trained, then the same system which can be also used with the results from those from this research process as a clinical expert system, so one which uses those scientific results in order to assist in the improvement of diagnosis and treatment of patients, and one which in the end aims to benefit the patients, who at the same time also become the contributors to the research of the platform. So we tried to incorporate those perspectives in the same loop in order to create a continuous system of improvement of clinical care through scientific medical research. So I will start the questions with the research perspective, and remember that we're talking about a loop where patients' data is used for the platform, because we are aiming to use real world data. To Javi and Luis, and you choose who will pick up the question. Can you discuss a little bit the unique challenges of integrating multiple data sources in MES-CoBraD, both in terms of the heterogeneity of the data, and also ensuring their reliability?
Okay. It's a nice question. I think we can do this like a whole discussion. Javi, you can talk when you think it's okay for you. In terms of data integration from with several types of different data, that was a big challenge, and still being for us, because we still developing the platform, etc. But we are dealing with data that are representing many different ways, or data that stores personal data in different ways, and to be able to build a whole platform that can merge, save, recognize those differences. It was for sure a big challenge, and I believe that a thing that contributed a lot for us to solve this problem was this good professional characteristics that we have. So we are working with people with different expertise, engineers from different fields, clinicians from different fields, and researchers from different fields. So I think this helped us a lot to solve this problem. Just to give you a normal usual example is difference between time series and normal questionnaire data, for example. Time series, you have to represent your data considering the time in a long way, and questions, you only have one representation of per time. So how are you going to merge this in the same data lake with the same aspects? And then regarding the quality of those variables that we are acquiring, in terms of project, we have some points to check, and we describe for every kind of data type that we are using in acquiring. We describe how to analyze them and how to check the quality of them, and then we follow this very, very, very much during those 2 last years. Javi, do you think you can talk something about how we can ensure data quality?
Yes, it is really challenging because in regards of the heterogeneity of the variables and the data acquired, and also the differences between the expertise of each site, because some sites are specialized in sleep, others in epilepsy, others in neurocognitive disorders. So we try to include as many as variables as possible, but also it implies the effort, the huge effort of participants and the caregivers, that they have to fill questionnaires, standardized questionnaires, and it could be a little challenging to try to complete the whole protocol as we want it. But I think that we are doing quite good. The quality control of the data right now is being done by each center, but we are achieving the KPIs that we have established. And well, now we are in the phase of data upload, where probably all this information that we are collecting will be more easily controlled for the quality tests, and then well, we are entering in a new phase in that sense.
All right, thank you. Another question also for the research perspective. We saw the technical perspective of the harmonization of the data. What about the possible biases and equitable representation and inclusion of populations in a study? Like, understandably, when designing a clinical study, you incorporate those from the beginning when designing the experiment. But here we're talking about real world data, which means that it's anyone who passes the doors. How do you treat that?
I think our project per se has the fact that we are different sites across Europe contribute to this question. So we are collecting data from different places, and since the beginning, I think we try to address that by considering and asking people some questions to at least account for this when we proceed with the analysis. So what kind of regions are more affected, or what kind of ethnicities are more represented here? What kind of ethnicity were not addressed, etc. So, in this sense, for the project, I think we were very, because this is not quite common for other projects to account for those differences and to account for those aspects. I don't know. What do you think about Javi?
Yeah, it is probably really different societies between sites, very different demographics that we have, and probably we will find important differences in some of the analytics that we perform. Is something that we cannot control at first, but probably once we have our data all together, we will be able to control that variables.
All right. So the answer lies in the type of collection of data, so you can debias it from the database rather than from the design of the experiment. And I suppose that would also mean that you have information that would allow you to also target specific research questions to specific populations in specific scenarios. So probably would broaden the ability to choose cohorts specifically to manage specific research questions. All right. I think we can move. Thank you. Both can move to the clinical perspective, and Ophira and Eliseo. So, can you explain what role the expert system for clinical guidance support plays for clinicians in the day-to-day work? So, literally, how would they use it when a patient visits them?
Sure, very happy to. Is it okay if I, Eliseo, go ahead? Okay, and I think we talked about this and the concept of an expert system, you know, and the specific vocabularies used by clinicians and computer scientists and experts. So I think it would be good to have an expert at the room sometime. I mean, if you're asking me how, so you have a patient, you insert their data or they insert their data, and you can, you know, ask, at least say it was me or, you know, or Javier or whatever clinician that contributed to the project, and see what they think without them being in the office. So this saves a lot of time and a lot of patient hours. And when you think about the required holistic care, you know, that we're going through, if you look at oncology, you know, in cancer therapy, this is where it's going on right now. And we're going to have to go that way. We're going to have a multidisciplinary session between different experts. And if they don't have to be in the room, they can contribute through, you know, medical device. I think that's a big win for the patient.
All right. So literally, I suppose that this is done when the doctor is left alone, when before giving out the diagnosis, not literally in the room with the patient. So who makes the decision is the question. Is it the expert system? Is it the clinician? How?
Yeah, I mean, this is very similar to the work we already practiced. It just in a more archaic level. So, and Eliseo's mentioned this. There's clinical guidelines. You know, there's observations that are made in research, and over time they drift and they become some kind of a clinical criteria to diagnose a disease. So you already have the expert in the room when you use it, clinical criteria. It's just much more primitive. So you have something, I think, which you'll have to use continuously, not when the patient leaves the room. It's a part of the conversation, you know, that you need to have. But like Eliseo said, this is still very preliminary. We don't want to get anyone here in the chat to think that this is, you know, going for family physicians and community neurologists. I think it has to be validated like every other clinical tool. But yes, I think it would be something that during the conversation it should occur.
And if I may, I mean, medicine is changing in its practice. We use electronic tools in clinic all the time, and even more we use ourselves to look something up. If a patient brings it up that it's out of our field of expertise, I think that's very valid. Also, you have to consider that some of the decisions that they're made with the clinician often clarifying and understanding the patient values and priorities. Francesca talked about the pillars of medical ethics, of including autonomy and justice and beneficence, non-maleficence. But in the setting of patient autonomy, even though the system may suggest or recommend that you pursue a certain path, you need to know that for some people that's not their decision, that they're fully informed, but that's not the path that they would take, and then you have to account for that and then re-guide the system. But I think the more and more we advance, the more and more, both for us but also for patients, the use of different tools, especially AI and machine learning tools, is critical to be accepted and understood for what it is. It doesn't have to do with the incompetence of a clinician. It has to do with the fact that they're actually competent in using additional tools to improve the care of their patients.
Thank you. In other words, it's the question, why would you continue to use horses if you have automobiles? So it enhances the ability of the human to provide answers to and provide guidance. Thank you both for that. So another question regarding the closing of the loop between clinical practice and research. If you need to know who the patient is when doing when using the expert system to provide guidance, how do you ensure that these data that are then re-uploaded to the platform remain non-identifiable for the patient that has contributed them? And so how would that model work for the open research question for the whole of medicine, many other research fields?
I can start this one. So the process as it goes now, you have a level of a data lake on the cloud, and you have a data lake within your institution at what we call the edge module. Whatever entry of data is done, it goes to the edge module. So there you also have, it's like being on your electronic health record in your institution. So the same principles apply, possibly even within the same servers for that person, for that purpose could be implemented. And then the tools that exist on the edge module to remove any identifiable information, remove any information, not just text, but also, as we said before, faces from MRIs or other, potentially in the future, as we collect, or other researchers collect voice recordings, that you can identify the voice of Elvis Presley, let's say, or something like that. So things like that, and such tools can be used to depersonalize the information you have. Then there are, I mentioned before, there's two different analytics. There's clinical analytics and there's research analytics. To the extent that the clinical analytics are involved, what you're really doing is you're entering one person's data into a flow which is already populated with what we would say a pre-structured model or coefficients. So you don't need to do on-the-fly analysis of unsupervised or supervised learning or other things like that. You have already done these analyses on the cloud. So the data in a clinical setting, it remains in the edge module and uses functions and flows that are in the edge module. You don't have to go to the cloud. The point of the cloud and the anonymization is for doing high level or more complex, if you want. If some of the information, let's say you have some type of analysis that your institution cannot, your server cannot support. Even if you need to export, let's say, the depersonalized information to the cloud, you can do that analysis on a research or, in the rare case, of a clinical setting. Let's say you need a very complex MRI EEG combination that needs a specific cluster of servers or something like that. I don't know. Then the information that is there, you cannot identify it. And then you feed it back. What is feed it back based on a specific hexadecimal code or something like that? That actually, I think, has an important potential for the future. And because we have structured it in such a way, that has to do with the European health data space. Because if you think forward that we do not have experts in all countries for all conditions to be able to care for people with specific diseases, brain or otherwise. And I need the expertise of São Paulo or eventually even Israel, if, based on the legal agreements between EU and Israel and so forth. And vice versa. Let's say São Paulo needs our expertise on, I don't know, sleep or something. A patient that is visiting here or who is agreeing to collaborate in a larger network of hospital systems or healthcare systems they can have their data accessed through such a process for clinical purposes. And there are some things, some aspects to consider in how do you do that, but it's done already in the United States through Care Everywhere systems. Similar systems can be applied, and the exchange of information doesn't have to involve any identifiable information, because individually the different healthcare systems can access the identity of the person within their edge module. Confuse you enough?
Yeah, that's fine. Thank you. Ophir, last question for this perspective. So, with this process, clinicians offer data that can be reused by themselves if they also wear the hat of the researcher, but can also be used by other researchers. So, what is the aim and the purpose of following such collaborative research practices in neurology and in medicine in general?
Yeah, well, I think there's a lot of outputs. Javier and Louise talked a little about this regarding your question in generalizability. I mean, you want to have an answer and a response that's generalizable to the specific patient that you see in front of you. He'll always be different. You know, you can't take 1,000 different parameters on a specific patient and assume that, you know, you read a paper or a research and that's specifically applicable to him. But the more samples we have and the more we know, we can say which is useful, which is inconsistent, which is meaningless, and which is relevant. And, you know, it's important for research, but it'll also become important for clinical practice. And I think that's what we want for data sharing at the end. Sometimes there'll be data that's, you know, not useful, not well curated, but some specific portions of it will be useful for your patient. So maybe something that's you know, acquired through a machine like an MRI or a PSG, or maybe even something that's just very simply clinical. And these collaborations will at the end help us, I think, deliver healthcare, but also understand complex brain disorders, changes in phenotype and how they look better.
All right, thank you, Ophir. Finally, the last section will be for the patient. So, question that I should address to Francesca first. So, Antonio and Francesca is up, and then have a couple of questions to ask Heather and Anne about what they understood from what we did describe here, and how they see it applied, and possibly consideration that they may have. So, Francesca, we talked a little bit about anonymization here before, and the process by which we try to keep patients' data safe, but a lot of people may ask the question, why would anonymization be necessary if it's for the common good? And is it something which should be considered in general, despite the fact that there are some people that do not really care for it, or is there a balance by which people are reasonably protected against being exposed to possible risks?
Thank you, Christos. Well, I mean, in this area, I think that the unique possible balance is the route we are taking. So anonymizing data, because otherwise it will be extremely risky for people that their health conditions data can be accessed from just everyone. Data can be used for not so good purposes other than research. And so it's a matter of respect. That is one of the first principles of medical ethics. We have to respect people right to privacy and to the control and the ownership of their data. So placing not anonymized data into a data lake just at disposal of everyone would be to infringe one of the rights of people participating in research. So I think that there is no other option for us in this project and in general in research.
All right, thank you, Francesca. Now, I'll address a couple of questions to Heather, and then I'll randomly ask Heather first. So, with your experience going through the epilepsy and dementia with your husband, and with your experience in healthcare, which I would understand is from a very different perspective than clinicians and obviously researchers who are already a little bit more removed from the process. How would you see this question of the use of research data, of sharing research data, anonymized or otherwise, in medicine in general? So how do you feel about the process and the contribution?
Yeah, I mean, yeah, I think it's very valuable myself, having sort of seen my husband going through sort of years of being treated for epilepsy. I appreciate that the more information that the clinicians can have to help them making their diagnosis. I mean, initially when he was first diagnosed with encephalitis, which led to the epilepsy, the doctor was Googling all over the world, talking to doctors all over the world. It was a lot of time and effort on his part. So I appreciate that, you know, doctors just don't work individually, and the more input they can have, the more valuable it will be. So yeah, so from my point of view, then I would very much welcome a system which took the data of lots of other patients who've had similar illnesses. I mean, I do appreciate that everybody's unique, everybody's different, so no one person is going to benefit in the same way as the next person. But your comments that you've made in that, you know, the more information you have, the more you're going to be able to say, yes, but this could work in this case. You know, we've got the similarities, we've got the differences. So yeah, I'd welcome it very much. And I appreciate it's so complex, listening to you all, trying to get the clinicians working. And that's a concern with me, with the clinicians. I mean, you've obviously got clinicians on board here, but my concern is it extra work for them as well, in that they will have an extra platform to upload data onto, but I don't understand your systems, so that's for you to deal with, not me. But that's a concern. Yeah, I'll shut up now.
Come on. So yeah, you're absolutely right that it's another system, and always when something is introduced, it needs to be tested in parallel with existing processes. So it is extra work, and it's supposed to be extra work because this is how we try to progress. And the long-term aim would be that those systems would be integrated in existing ones, so that they wouldn't have to use it separately. Currently, as it stands, because it's an isolated project compared to the existing systems that they use, the health record systems and the laboratory systems. The aim would be to integrate it into all of that, so that they don't have to do the uploading and all that. So I understand that you see the contribution of research data as participation in a community, of people that have that are facing similar issues, similar disease, and that participation in that community is what drives your will to share, so that both you have the sense of actual contribution to research and science and the welfare of people, but also reap the benefits from that contribution in the short, medium, and long-term aspects of these diseases. Thank you very much, Heather. And Anne, how do you see the use of artificial intelligence in systems like that? So what we call expert systems. How do you expect to see that being used? Because it's something quite discussed lately, at least in the past year, and there are a lot of fears of dystopian futures where people are out of the equation and substituted by humans. Do you see this as a first step towards that direction, or you see it as something of value or of a positive contribution to people's well-being?
Still on mute. I think for me personally, our experience of dystopia was the future of our daughter without treatment and without diagnosis. And I think if you're presented with a condition that there are no answers to, or there's doubt about, or there's a really long delay in diagnosis, then you worry an awful lot less about imaginary dystopia futures, and you worry a lot more about whether your daughter will arrive home from school alive because she has seizures that cause her to fall down. So I think imaginary dystopia probably goes out the window when you are presented with these kind of challenges. I think as those of you who are clinicians probably know and experience, when people come to medical teams, particularly when they're coming to a specialist and there's something rare going on, there's the magical thinking of white coat syndrome. And I think behind some of that magical thinking is often some imagination that kind of AI is in the head of that consultant already. You know, we come to specialists and we hope that you know everything in the whole wide world. And it's actually a surprise when you can't know everything. And so actually AI is a way of bringing that everything to you, and can only add to the scenario of being able to help questions be answered. And then, you know, in a very practical way, when you go through what we went through in terms of this extraordinary successful surgery at King's, you become a little microcosm of AI in that other families who are about to go through this, you become their repository. So I still, 8 years after my daughter's surgery, I still get phone calls from people who want me to give them that piece of information about my daughter and about how the surgery worked. People want to find access that information somehow. And there's loads of informal ways of that happening out in the system even after successful diagnosis and cures and surgeries. So I think patients and communities expect that there's some sort of version of AI out there anyway.
Right. Yeah. This is a very valid point, and this is actually what I alluded to before. That if you're in need, you don't really care about so much about privacy or artificial intelligence in everyday life. It's as they say, those questions are first world problems, and the actual issues that people face with difficult diseases like epilepsy, and generally the kinds of disorders that we're dealing here are ones which are they do affect everyday life, and they do affect normal function, and they do affect cognitive ability, and they are detrimental to people's future if not treated right. So I do understand that it goes out the window. Yeah.
And also one other point from our personal experience is the unbelievable time lag in getting the right test done and the right diagnosis done. And the only safe way of managing NHS resources or medical resources is to put long gaps in before you put in the next expensive test and the next expensive test. And I think something like this would speed up the whole side of the process so much. I mean, so much.
Yeah.
That was one of the major drivers, I think, too. So
I
it's
mean,
good to
it's
hear.
kind of prehistoric to describe how the process went for our daughter, because there was no other way around it. And as it happens, surgery was the obvious, very simple for a brain surgeon, but it was the thing to do. But she first started getting seizures that caused her to literally hit the floor when she was 11 and was cured when she was 15. And in the meantime, were there all those years where she was daily at a life-threatening risk that could have been shortened phenomenally if you had this kind of data, if you were able to gather this kind of data. And the other thing about neurological symptoms is that it would appear that there are kind of slight questions as to what's real, what's imaginary, what's functional rather than clinical. We had a son who had died a few years earlier of a rare condition. And so I think there was a little question mark over our family as to whether we were imagining our child being at life risk. If you had a way of gathering this kind of data, the kind of real life, what Antonia saw on EEGs about her, that delay would never have happened because she was clearly had an insane EEG. We weren't, imagining a neurological symptom due to bereavement. She had a neurological, but we were delayed and massively, I think, because of some of this. Sorry, I will shut up.
No, man, thank you so much for sharing. I mean, we all do a little bit, we talk to our patient public involvement is something we actively all do. And I think these kind of stories are so important. Really, thank you so much for sharing it. And I know this entity, which we sometimes call functional. Functional is I think the new or modest term. But it's important to say that before there were any tests, everything was essentially functional. It just means that we've never never invented a new MRI or a new PET, to see what really is functional. So thank you for sharing.
Thank you, really.
I'm going to jump in because we are over time. I'd just echo what's already been said and thank all the speakers, and especially Heather and Anne, for taking the time to join us today. It's really important to hear to get them different perspectives also from outside the project. So yeah, that's everything. Again, thanks everyone. On the 20th of November, we will have another project event with two sister projects that we've been collaborating with. There'll be details on the project website, which I'd encourage you to visit if you are interested in hearing more. But besides that, thanks everyone. Thanks to all the speakers, Heather and Anne. And yeah, I wish you a nice rest of the day.
Thank you all.
Thank you all. Thank you. Bye.
Bye-bye.
Thank you. Bye. Thank you.
Thank you. Bye-bye.
Thank you, everyone.